Okay. Good morning, good afternoon, good evening to everyone. I am Tevfik Kıvılcım from Istanbul, greeting from Istanbul, and it's my pleasure to be your host for today's session with Dr. Partgada. Welcome to our highly anticipated webinar on endoscopic ultrasound. This is an invaluable tool in modern medicine, and we have needed day by day and increases of using it. I am delighted to see various participants from around the world, and they represent the very diverse community of healthcare professionals, researchers who are enthusiastic about to delve into the world of endoscopic ultrasound. We have fantastic lineup prepared and featuring renowned expert in the field who has dedicated their career advancing and understanding the application of endoscopic ultrasound. I would like to express my gratitude to each and every one of you for you taking the time to be with us today. I want to hand over to Dr. Part to introduce panelists. Dr. Part.
Thank you. So it gives me great pleasure to introduce to you our panelist for the day. I would like to introduce Dr. Sunil Kumar. He is the honorary professor and has been the former HOD of Tata Main Hospital in Jamshedpur, where he has been with that hospital for more than 20 years. He has also been awarded the Best Teacher Award and for medical excellence by the NBE. He has also spent many years working in the NHS in UK previously, and he has been instrumental also in successfully organizing a lot of programs of ASI in Jharkhand. We are truly, it's a pleasure for us to have you as a panelist over here. Dr. Masfiq who was another panelist, has not been able to join today. I would request Dr. Tawfiq to introduce Dr. Dalal now.
Okay, it's my honor to introduce our distinguished speaker for today, Dr. Ankit Dalal. He's a gold medal recipient for gastroenterology from National Board of Examination and working as consultant gastroenterologist in Mumbai. He has vast experience in the field of gastroenterology with special focus on pancreatobiliary disease, inflammatory bowel disease, and GI oncology, IBC, and therapeutic endoscopy. Okay, and he has specialized in advanced endoscopy procedures like ERCP, diagnostic and therapeutic EUS. I think his wealth of knowledge and experience will undoubtedly enrich our understanding of endoscopic ultrasound and its applications. Feel free to actively participate and please ask questions from the chat box. And thank you again for being part of this educational experience. And without any delay, Dr. Ankit Dalal, the floor is yours. Thank you.
Thank you. Thank you for the kind words. And thank you all panelists and moderators and the people behind TUGSS for inviting me for this talk. So I've been given a very broad topic of talking about endoscopic ultrasound, which has now become a field of endoscopy within endoscopy, wherein we have specialists in EUS, we have dedicated conferences just on EUS, and it's a field which has come up dramatically in the last 10-15 years, and the therapeutic potential of EUS is just being explored now, which is booming all across. So what I'm going to do is give everyone a brief overview of what EUS was and what EUS is capable of now. I'm not going to delve too deep into academics or data. I'm just going to show you certain procedures which have now come up and what we are able to do with the EUS. So without further delay, I'll start my presentation, and I hope you're able to see the slides.
Yeah.
Okay, so let's talk about EUS. Okay, so EUS was first introduced way back in 1982, and the aim of this scope was that we should be able to see or assess a disease process within the walls of the GI lumen, like whether it is In mucosal, it's submucosal, or it is a muscular problem, or even assess structures or diseases outside of the GI tract, which are in close vicinity. So is it like your pancreas, the pancreatic duct, the biliary space, or the peritoneum, etc. So this was the aim of developing the endoscopic ultrasound, which was described in 1982. So at that point, the scopes were rather bulky. They were rather difficult to use. They had very poor vision. They had very poor image quality, and they were extremely bulky, very difficult to use scopes. But over time, over time, as in over the next 15 years, 20 years, people started to understand EUS. They started to understand the benefits of EUS. And when we came in with a specialized scope, which is the linear echo endoscope, that's when things changed dramatically, because the linear echo endoscope allowed us to take biopsies, take tissue samples, and then subsequently over the last 5, 10 years, a lot of therapeutic potential has come up with the help of linear echo endoscopes. So here, basically, it's just your equipment. You have your EUS processor, you have different types of echo endoscope, your radial echo endoscope, and the linear echo endoscope. And we also have something which is called a forward viewing echo endoscope. That is a very specialized scope which can be used in certain situations, especially therapeutic procedures. And we also have this mini probe, which I'll talk about. So a radial echo endoscope, basically, it's the first echo endoscope which was ever introduced to us, and it allows us a 360-degree view in the plane perpendicular to that of the scope. So the image, if you can see, it is pretty much like a CT image. You get a complete detailed picture of everything. You can see your pancreatic duct, your portal vein, CBD in its entire length when you are scanning. So it is an extremely wonderful tool to give us a great diagnostic image. But it had limitations. You couldn't take biopsy samples because there's no way you can image a needle coming out through this scope. So there was this unmet need. That's why the linear EUS, which is the linear echo endoscope, came into the market, which provides us a localized oblique view image parallel to the scope. And then it allows us to visualize needles passing through the scope into the target tissue to acquire biopsies, to perform therapeutic procedures, etc. So now in practice, essentially most endocrinologists prefer using the linear EUS. Linear EUS requires a little bit of more training as compared to the radial EUS, which is quite simple. But once you have achieved that level of training with linear EUS, you really don't require a radial echo endoscope for your practice. So nowadays, I would recommend, like, if anyone is planning to set up a practice with EUS, linear EUS scope is the one EUS scope which you should have. You need not have a radial echo endoscope. You can easily perform all your diagnostics, therapeutics, etc. using the linear EUS scope. And we have a special scope which is called a mini probe. So this is a very tiny 2.8 millimeter probe which can go in through your regular endoscope, regular upper GI endoscope, which can be passed through the biopsy channel of this endoscope. And this is useful, especially when you have tight strictures in which your regular EUS scopes cannot go through, or you are doing intraductal EUS, which is especially done in bile duct. So if you are suspecting a lesion or a cholangiocarcinoma in the bile duct, you can perform something called an intraductal EUS, which helps us in localizing and diagnosing cholangiocarcinomas. Then came accessories and EUS specific stents for therapy. So main accessories for EUS is your needles. You have different sizes of needles. I'll just briefly touch on that. For biopsy sampling, you have dedicated guide wires, balloons, etc. for performing therapy. And then the major advantage or the major development that came in with therapeutic EUS was these EUS specific stents. So these are what we call lumen opposing stents, which is your Axios stent or the Paxos stent or the Nagi stent. So these are what we call covered stents. They have flanges on each side, as you can see, and a saddle in the middle. And what these stents have is a lumen opposing force. So they tend to bring two lumens together. So with the help of this, you can create anastomosis. You can create lumen to lumen anastomosis. So whether it is for draining a pancreatic fluid collection or draining a gallbladder or performing a gastrojejunostomy with the help of EUS, these stents, because of their lumen opposing force and these flanges, they do not tend to migrate and they tend to bring the two lumens together. So let's begin all about EUS. So what are the current indications of performing EUS? Staging of GI malignancies, whether it's esophageal, rectal, stomach. You can visualize lesions within the GI tract and define the T and N stages. Pancreatobiliary diseases, it is the most commonly used modality for evaluation any kind of pancreatobiliary disease. Subepithelial lesions like your GIST, leiomyomas, neuroendocrine tumors. Again, assessing extraluminal abnormalities, lymph nodes, pelvic fluid collections, splenic collections, etc. And of course, therapeutic EUS, which is a different field altogether. So when we look at imaging, so this is a radial EUS image. When we have high frequency imaging using the radial EUS, what we can see is the actual delineation of the layers of the GI wall. So what we are seeing here is an esophageal wall where we can define the each and every layer of the esophagus wall, which is the mucosa, the muscularis mucosa, the submucosa, the muscularis propria, and the outer layer, which is the adventitia or a serosa, depending on where you are imaging. So typically your muscle layer will appear hypoechoic or dark in nature, whereas your mucosa, submucosa, or serosa will become bright. So you can easily identify where a subepithelial lesion is arising from, or if you are assessing GI malignancies, to see where it is arising from and to assess the depth of invasion of the lesion. This is mainly because nowadays we are screening for patients who have early GI tumors like your esophageal or gastric. So we exactly want to know how deep the invasion is before planning the resection, whether endoscopic or surgical. So briefly, so if you're looking at, say, esophageal cancer, so EUS and esophageal cancer, you are doing a screening endoscopy, and we find this on image enhanced endoscopy, which is NBE. You see some dilated blood vessels, dilated capillary loops, and you are certain that this is suspicious of an early esophageal lesion. This is what you see after injecting Lugol's iodine, chromoendoscopy, and the unstained area is what you're looking at as the suspicious area. And then you do EUS. And in EUS, if you can see the area here, you can identify the walls of the esophagus here. And there is this hypoechoic area over here, which is, invading the walls of the esophagus. And you can see that this lesion is going up to the muscularis over here. And this lesion, although it may appear to be resectable, it is an early lesion. There is not a nodule, there is no ulcer, and you may consider endoscopic resection, but on EUS, you can see that the lesion has invaded into the muscle. And so this case would not be an ideal case for an endoscopic resection. So similarly, if you have a larger lesion on an EUS, you see this, that the entire lesion has gone across the adventitia and going deep across outside of the esophageal wall. And you can identify this as to be an advanced lesion, which is showing deeper invasion. So EUS helps us in staging, T staging, and also in loco-regional staging. So you can identify small lymph nodes around the lesion. So this is again an endoscopic view of an ulcerated lesion in the esophagus. You see this circumferential hypoechoic lesion in the esophagus, which is the tumor, and you see a small perilesional lymph node, which may be sometimes missed on your CT scan or your PET CT. So if you look at EUS for superficial esophageal tumor, you have a very good sensitivity specificity for assessment of mucosal versus submucosal invasion. And also for regional node assessment, EUS with biopsy has higher sensitivity specificity compared to your CT or your PET scan. So especially for loco-regional staging, for your local nodes, EUS tends to perform better. Again, so another caveat, like if you have a lesion in the esophagus which is obstructing, or it is a large nodular lesion, there's no point of doing EUS because usually these lesions will be deep. So ideal candidates for esophageal tumor screening are those which are early flat lesions which are picked up on image enhanced endoscopy, and you want to know the depth of the lesion and any loco-regional spread. Patients who come in with dysphagia or who have obvious lesions in the esophagus, they may not require an EUS because you'll not gain any added advantage or added knowledge. So then let's come to pancreatobiliary diseases. So these are like a lot of indications for performing EUS in pancreatobiliary diseases. So you have assessment for gallbladder stones, bile duct stones, cholangiocarcinomas, ampullary neoplasms, choledochal cysts, stenosis, strictures, etc. And for pancreas, assessment for chronic pancreatitis, pancreatic carcinoma, for recurrent acute pancreatitis, cystic neoplasm of pancreas. So the indications for EUS is present for all these situations. So what I'll just show is certain cases. So you have a patients who are coming in for suspected for gallbladder stones, and they have abdominal pain, and they have a dilated bile duct without any obvious stone in the bile duct on your imaging initially. And you have, see, this is the bile duct over here with the green arrow, and this is the portal vein. This is the linear EUS image, which is showing you a portal vein and the bile duct below. So this, what we are seeing here with the cursor, is the portal vein at the hilum, and that's the bile duct below it. And this is at the liver hilum. This, what we are visualizing, is from the stomach itself. And then as we go in gradually, we can see that this bile duct is entering into the pancreatic parenchyma in the head of the pancreas. And we can trace the bile duct all the way till the ampulla over here. And as we are tracing, we can see some shadowing over here. We can see some acoustic shadowing which is occurring over here, and that's diagnostic of a CBD stone. So EUS in several studies has been shown that it performs better compared to your CT scans, ultrasound for detecting bile duct stones. Compared to MRCP, EUS is more sensitive and specific for detecting smaller stones, especially stones which are less than 3 millimeters in size. These stones can be easily picked up on EUS, which can be missed on MRCP. So if the clinical suspicion is high, performing an EUS before doing an ERCP or a gallbladder surgery is warranted. Similarly, for picking up early chronic pancreatitis, EUS remains a modality of choice. Uh, there are certain features on EUS which can help us pick up chronic pancreatitis. So when we see parenchyma, which is showing strands, which is showing some lobularity, which is showing not just calcifications, but hyperechoic strands, lobularity, and some hyperechoic dots, these are certain features that can help us identify early chronic pancreatitis. Obviously, this patient also has a mildly dilated pancreatic duct over here with a stone inside the pancreatic duct, which was a radiolucent stone, which was missed on imaging studies elsewhere. And it is a wonderful tool for diagnostic ampullary lesions. So here we are doing an EUS, linear EUS from the ampulla. And what we see here, this tiny hypoechoic lesion over here is an ampullary adenoma. So it's very essential for us to assess these lesions first on EUS before, as you can see here, this is the lesion which is just come up into the ampulla, which is a tiny lesion within the ampulla of Vater, which is causing obstruction of the bile duct. So EUS is very essential in assessing ampullary lesions before we can subject them for ampulectomy or surgical resection. So in situations wherein the lesion is invading into the duct, it is too large, something of that sort, it is not easy for us to remove it endoscopically. But if the lesion is not invading into the duct, it is localized to the ampulla, we can offer these patients ampulectomy and can avoid a major surgery. So EUS helps us in assessing the local staging of ampullary lesions and are deciding about the future course of action. Similarly, for CA pancreas, it is a well-known tool. We can easily identify the lesion in the pancreas, assess the local staging, whether the lesion is adherent, abutting, invading into the surrounding vessels. As you can see here, there's a lesion in the head of the pancreas with some thickening and involvement of the SMA and the SMV. And so local staging of the pancreas to decide about treatment can be done very well on EUS. So it is a complementary method, I would say, in staging of pancreatic cancers, with which you can assess the local vascular status of the tumor and decide about surgery. Again, cholangiocarcinomas, we can see this is a dilated duct over here. As we trace the duct into towards the papilla, we can see a lesion which is coming up into the duct. So this is a small early cholangiocarcinoma that we have picked up on EUS. We can take samplings from this lesion and confirm the diagnosis before subjecting patients to the surgery. So as we can see, EUS gives us high quality images for small lesions, for difficult lesions, which are difficult to get samplings on either an ultrasound or a CT guided. But with EUS, we can easily sample these lesions. So we have just a brief overview of all of this, that EUS is more accurate than CT or MRI in detecting small CBD stones. For detecting small pancreatic tumors, especially less than 2 centimeters or 1 centimeter, EUS scores high as compared to CT or PET. Again, early chronic pancreatitis with the presence of strands, dots, etc. You can detect early pancreatitis. And doing FNA, especially in combination with ERCP brushing, can increase the diagnosis of distal cholangio. So let's briefly talk about subepithelial lesions. So these are all the subepithelial lesions that we see: a GIST, leiomyoma, lipomas, neuroendocrine tumors, duplication cysts, etc. Most commonly, what we come across are GISTs and leiomyomas, and assessment of these lesions with the help of EUS becomes rather simple. So you have these appearances of the lesions which are arising from the GI wall. So you have a GIST arising from the muscularis layer, similarly a leiomyoma, and the schwannoma, which typically arise from the muscularis layer. You can perform biopsy from these lesions to confirm the diagnosis before treatment. You have here the first image, that of a lipoma, which appears hyperechoic compared to the rest of the lesion. So you can easily identify a lipoma. This is an appearance of a neuroendocrine tumor in the duodenum, which appears as a small hypoechoic lesion, which is arising from the submucosa and adherent to the muscularis. And this is a pancreatic crest. It is an ectopic pancreas seen in the antrum, again, which appears as a small hypoechoic lesion arising from the submucosa of the GI wall. So with the help of EUS, you can assess the layer of origin of these lesions, characterize them, take sampling if required. And many a times nowadays, we can remove these lesions endoscopically if we are sure that these lesions are not going too deep or crossing into the muscularis. So let's come to tissue acquisition, which is a next step in EUS, from diagnostic to getting actual tissue for biopsy and assessment. So this is a lesion in the pancreatic body. It's with the passage of a needle using the linear EUS scope. We can pass a needle under vision, take samples, and now it is well proven that the diagnostic rate of any lesion with the help of EUS is very high, with more than 90% sensitivity specificity. It leads to change in the management, especially in patients with subepithelial lesions. It is safe. The risk of needle tract seeding is minimal. And since we are sampling most of the tumors in the pancreatic head from the duodenum, it comes out in the surgical specimen. So if at all there is some seeding, which is theoretically possible, it is not of clinical significance subsequently. So over time, the type of needles have changed. We initially began using just the FNA needles, which gave us only cytology samples. But now, over the last 5 years, we have progressed into biopsy needles, which are the FNB needles, which have these specialized tips. They are sharp cutting edges, which, when we pass into the tissue, give us actual cores of tissue, like you would get in a true cut needle. So nowadays, we have switched over from doing just FNA to FNB for almost all lesions in the GI tract. Except for cystic lesions, we are still using FNA needles because biopsy needles are a little traumatic for cystic lesions. But other than that, for all solid lesions, for lymph nodes, for subepithelial lesions, the FNB needles provide cores of tissues which can be subjected to histopathology rather than cytology. So you can run immunohistochemistry tests, you can run specialized molecular tests, PCR tests, etc., and come to a conclusion. So as I said, these are the kind of core tissues that you get when you use FNB needles. So they have high diagnostic yield. As I said, core tissues which preserve the tissue architecture. You need fewer passes. We are also performing liver biopsies now with these needles, and the kind of tissues that we are getting are comparable to percutaneous liver biopsies, although it is a bit more expensive than percutaneous liver biopsies. But if you are considering doing an endoscopy in a patient for suspected varices and you want to do a liver biopsy, you can do it at the same sitting and you can cut down on costs accordingly. So there's a small opportunity in certain patients who want sedation, who want an endoscopy, and who also require a liver biopsy. We can do it EUS guided. As I said, we can perform IHC, PCR, culture tests, etc. There's no requirement of something called ROSE. So ROSE was a rapid on-site cytopathology examination, which was earlier needed with FNA needles. But with the advantage of FNB needles, when we get such codes, there's no need of a person to assess the sample on the spot to tell us whether the sample is adequate or no. Again, the same thing as I said, for solid lesions, sensitivity specificity in excess of 95%, lymph nodes again very high. The problem still arises with cystic pancreatic neoplasms because of the nature that the sensitivity is low, but the specificity is quite high. And there are certain specialized biopsy techniques which have come in for cystic neoplasms, wherein we can sample the wall or assess the wall of the cystic neoplasm and come to a conclusion. So even there are developments being made in terms of sampling. Then we have something called enhanced imaging, which can help us in tissue diagnosis. So the first one is contrast EUS, which is we inject a contrast agent, SonoView, which helps us identify lesions. So here we have a case of a pancreatic neoplasm, and after injecting of contrast, we can see that the lesion is hypoenhancing, which is typically seen in adenocarcinomas. And we can diagnose, even though if your biopsy turns out negative, or the sample is inadequate, with the use of contrast EUS, we are able to assess these lesions. So if you have a lesion which is hyper-enhancing, you are looking at a neuroendocrine tumor. Whereas if you're looking at a hypo-enhancing lesion, it's typically an adenocarcinoma. Similarly, we have something called EUS elastography, which is a real-time assessment in the newer scopes, wherein we can, this color charting comes on the target lesion, and if the lesion is neoplastic, it appears blue in nature, which signifies that it is a hard lesion, malignant lesion. And if you have a heterogeneous lesion, which is a mix of green and red in color, it is a softer lesion, more likely to be inflammatory in nature. So with these two techniques, which are enhanced imaging in EUS, we can assess the malignant potential of the lesions. So as I described about elastography, you have a lesion which is like a neuroendocrine tumor which appears uniformly blue and hard in nature. Similarly, an adenocarcinoma which is also hard blue in nature, whereas a benign inflammatory mass will appear greenish. So we can differentiate between hard tissue and soft tissue, which will help us identify malignant or benign lesions. This is not an absolute. We still need biopsy confirmation, but this is an adjunct which can help us direct our biopsy needles and can give us additional information about the nature of the lesion. Again, as I said about the contrast EUS, hypoenhancement for adenocarcinomas and hyperenhancement for neuroendocrine tumors. And these techniques have very high sensitivity, specificity, and we can identify the target for EUS FNA, especially in smaller lesions, which can be missed, and can also assess the malignant potential. So contrast EUS and elastography really help us in patients who have, say, a negative biopsy sampling and we are still suspecting a tumor or a malignant process. Then let's come to therapeutic EUS. So what all can we perform? So these are the simple, or these are the ones which are commonly done by us in the day-to-day practice: pancreatic fluid drainage, biliary drainages, treatment of gastric varices, pancreatic duct drainage, gallbladder drainage, gastroenterostomies, celiac, solid pancreatic lesions. And we are able to do this because of these specialized stents. So I had already described you all these lumen opposing stents before, and I'll just show you some videos of how these stents come in use. So this is a patient with a bleeding gastric varix. So the routine treatment was endoscopic treatment with glue injection. And what happens with regular endoscopic treatment is that sometimes your vision may not be right. The stomach may be filled with blood and you may not be able to assess. But on EUS, you can easily identify these dilated blood vessels, the dilated varices. You puncture them with a needle, you inject coils in them, you visualize using Doppler the presence of the coil, and after you injected multiple coils inside, you can inject glue into these varices and obliterate them completely. So here we had injected couple of coils into the varices, following which we injected glue into the varices. And then real time, you can use Doppler during the therapy to assess if the varix has been completely obliterated or no. So now we are shifting over from actual endoscopic therapy for GI varices to EUS guided. So here you can see after the therapy, the entire varix has been obliterated. There's no Doppler flow, and you are pretty sure that your therapy is complete. Similarly, pancreatic fluid drainage, most of the patients who come in with a pseudocyst or a walled off necrosis can be tackled with endoscopic therapy, especially in collections which are localized into the lesser sac, who do not have paracolic extensions, who do not have multiple collections and a single large localized collection. They can be tackled very well if they are close to the GI tract, either the stomach or the duodenum. So here you have a first case wherein you see a large walled off necrosis with debris inside. You go ahead with EUS guided drainage. You place in a stent, which is here. After puncturing the cyst, you dilate the tract with a balloon, and then you leave a self-expanding metal stand. This is the metal stand that I was talking about, the lumen opposing metal stand. You placed it inside, you see a gush of fluid which comes out. You can dilate this stent, and then you can go in with your regular endoscope and perform what is called a direct endoscopic necrosectomy. So what we see here is the solid debris within the walled off necrosis. You go in with your endoscope and you can remove this necrosis using a snare or a basket and completely clean the cavity. So this is now a regular feature of endoscopic therapy for pancreatic fluid collections and for walled off necrosis, that you would go in and clear out the contents. Similar, the second video is that of a lumen opposing stent. So here you have a specialized stent which does not require a lot of steps. We go in with an EUS scope, you see a bulge in the GI lumen. We assess it's a large cavity, maybe measuring more than 15 centimeters in size. And with the help of this new stent, which is called an Axios stent, it's an electrocautery enhanced stent. So you don't need multiple devices. With the stent itself, you can puncture this collection and deploy the stent in a single step. So we have already punctured the collection with the stent, and now we are going to deploy the stent within the cavity under EUS. This is the distal flange which has opened up into the cavity, and then you deploy the proximal flange within the stomach, and your drainage is complete. And you see the gush of fluid which comes out. So this actually makes the process of drainage a 10-minute performance. It takes 10 minutes for us to deploy this lumen opposing stent, which can drain the collections. Biliary drainages, again, it's a well-found, well-developed procedure. There are several steps, there are several ways we can drain the bile ducts when an ERCP fails, or there is a surgically altered anatomy. We can do an antegrade stenting, which is puncturing the liver and then passing a guide wire across the bile duct into the ampulla, across the ampulla into the duodenum, and then performing placing in a stent, similar to something like a PTBD, that you would place a stent after puncture here. You pass a guide wire through the stricture across the papilla, and then under fluoroscopy guidance, you leave a metallic stent into the duodenum. You have something called a duodenostomy, wherein you are puncturing the bile duct transduodenally. You inject contrast. This is typically done in patients who have a distal biliary malignancy, and your ERCP has failed or ERCP is not possible, and you would do an EUS guided puncture of the bile duct from the duodenum and then leave a stent in the bile duct through the duodenum, performing a choledochoduodenostomy. Another technique is a hepaticogastrostomy. So in patients with an obstructed biliary system and gastric outlet obstruction, wherein we cannot do an ERCP, we cannot pass a duodenoscope into the duodenum. We puncture the bile duct from the left lobe of the liver, the segment 3 of the liver. We inject contrast and we delineate the anatomy. And then after that, after guide wire has been passed, a tract has been formed, we leave a stent between the left lobe of the liver and into the stomach. And this is a specialized stent which is partially uncovered and partially covered, which is then left into the stomach, which would then drain the liver and get relief palliation of the obstructed bile duct. So these are some of the basic brief biliary drainages that we perform under EUS guidance. Similarly, we can drain pancreatic ducts as well. So this is a patient post Whipple's who has developed an anastomotic stricture. We punctured the pancreatic duct from the stomach. You can see a dilated pancreatic duct here. We pass a guide wire, we dilate the tract, and then we leave a stent within the pancreatic duct and the stomach, performing a pancreaticogastrostomy for patients in the surgically altered anatomy who have developed problems of the pancreatic duct. So even for patients who have failed ERCPs, we can perform something like pancreatic rendezvous. Here we've placed a metallic stent in between the pancreatic duct and the stomach wall and drain the pancreatic duct. Other technique which has come in is a gallbladder drainage. So now again, gallbladder drainage is done EUS guided in patients who aren't surgical candidates, who have come in with acute cholecystitis. So instead of doing a percutaneous cholecystostomy, it has been shown in several studies that EUS guided gallbladder drainage through the stomach or the duodenum using these specialized metallic stents, which are the Axios stents, are much better than performing percutaneous cholecystostomy. The failure rate, the adverse events of cholecystostomy percutaneous are much higher compared to internal drainage. So especially this is done in patients who are not surgical fit candidates and who require some drainage of the gallbladder due to cholecystitis. And we can perform EUS guided drainage of the gallbladder. And again, this is the Axios stent which we are deploying in the gallbladder. And it's safe, technically easy job, and we can see that the gallbladder is easily drained into the GI tract. Again, this is another video which is a patient who had undergone percutaneous cholecystostomy but was not responding, and we performed gallbladder drainage using the cautery device. So we place the cautery device into the gallbladder, we release the stents inside the gallbladder, and then we can see drainage of the gallbladder fluid, the pus within the GI tract. So this is in comparison to percutaneous cholecystostomy, EUS guided drainage definitely scores better in patients who are not fit candidates for surgery and who require urgent drainage of the gallbladder. The next thing that has come up now is gastrojejunostomy. So patients who have malignant gastric outlet obstructions due to CA pancreas or duodenal tumors, ampullary tumors, which is causing obstruction of the distal stomach and the proximal small bowel. We can perform EUS guided drainages of or EUS guided gastrojejunostomy. So here there is a patient who has had a gastric outlet obstruction. We pass a guide wire under fluoroscopy deep into the small bowel. We withdraw this scope and then pass in a regular EUS scope. And what we do is we insufflate or instill a lot of saline and distend the small bowel. So this is a specialized balloon catheter which goes into the small bowel. And after placing this catheter into the small bowel, we inflate balloons and then distend the small bowel in between them. So here you see the two balloons which have been insufflated. And then in the intervening segment, we instill contrast and methylene blue tinged saline and we distend the small bowel. Once the small bowel has been fully distended, what we do is pass in our linear EUS scope, which I'll just show now. So the linear EUS scope goes in, it identifies the distended small bowel here. This is the distended small bowel loop, which has been filled with saline. And we puncture this loop again with the same device, which is the hot Axios device. We deploy the distal flange within the lumen and the proximal stent in the stomach. And thus we have created a gastrojejunal anastomosis. Now, if we talk about data, there whatever data is available, comparing it with surgical GJ, it shows comparable clinical and technical success. The advantage of endoscopic GJ or gastrojejunostomy is in terms of safety. The adverse event rates are much lower with EUS GJ. The recovery rates are faster. The patients are able to take liquids and subsequently soft diet immediately within the next 24 to 36 hours after the procedure. The only risk of this procedure is stent misdeployment, wherein you can occasionally deploy the stent into the peritoneum. In such situations, again, it is not too difficult because we use CO2. So we just remove the stent, close the defect in the stomach using clips, and then we can attempt a replace or a repuncture and redeployment of the same stent in the same sitting. So it scores over surgical GJ only in terms of better safety and increased recovery. And yeah, efficacy wise, the clinical and the technical success is equal for surgical GJ and endoscopic GJ. Although we do need head-to-head trials to say this, but the literature so far says that it is comparable. So in patients who have malignant gastric outlet obstruction due to advanced diseases and who need a bypass palliative procedure, EUSGJ scores. And if we compare it to enteral stenting, which was available before, this is definitely better because it goes away from the tumor. There's no risk of tumor ingrowth or stent malfunction later on. So as endoscopists, we are preferring to do EUSGJ over enteral stenting in patients who have gastric outlet obstruction due to advanced malignancy. Again, so this is now a novel procedure that we are using with the help of this special stent. So in patients who have undergone a bariatric procedure, a gastric bypass, and who now have a CBD stone, which is causing issues, it's a tricky procedure. Like you need to do a laparoscopic assisted ERCP previously. But now with the help of these stents, what we do is first we inject into the remnant stomach, inflate the remnant stomach here like this, and then we place a stent, the same stent that I had shown you. It is a 20 millimeter stent. So we place the stent between the remnant stomach and the gastric pouch like this, which forms a conduit for a passage of our ERCP scope. So once we place the stent, you dilate the stent, you fix the stent with some suturing device, and then you can pass your regular ERCP scope through this stent into the remnant stomach and perform what we call as a edge procedure. So with the help of this, we can do a regular ERCP. And so you can see here now the duodenoscope has passed through the stent into the remnant stomach, and we visualize the ampulla, and we can carry out a regular ERCP rather than doing something like a laparoscopic assisted ERCP. What after this? So you can easily reverse this procedure by removing the stent and suturing up the defect in the gastric pouch side. And so the patient does not have a reversal of his surgery. What other procedures do we do? So we can do EUS guided celiac plexus neurolysis in patients who have advanced pancreatic cancer related pain. We can block the celiac plexus by injecting alcohol and bupivacaine. EUS pancreatic ductal interventions, as I already said, we can do EUS guided pancreaticogastrostomies, rendezvous procedures. We can perform RFA for pancreatic neoplasms, especially patients with neuroendocrine tumors like insulinomas, who are not candidates for surgery or who are too tiny. We can target these lesions under EUS and perform RFA for these lesions, burn these tissues, and these patients get good relief. We can do EUS guided injection therapy for pancreatic cystic neoplasms, so patients who have IPMNs or mucinous cystic neoplasms who are not candidates for surgery. We can aspirate the fluid contents and then inject alcohol into the cystic lesions to ablate them. EUS guided brachytherapy is available, wherein we can inject chemotherapeutic agents directly into the tissue. We can inject fiducials into the target tissue for better radiation. And therapy for portal hypertension, as I already mentioned, treatment for gastric varices. Now we can also perform EUS guided portal pressure measurement akin to HVPG for patients with chronic liver disease. we can perform EUS guided assessment of the portal venous pressures, which can avoid your HVPG or transjugular biopsies. So I'll just end here to summarize, like EUS has become a really an invaluable tool for diagnosis and now therapy for gastrointestinal disorders. Tissue acquisition diagnostic role of EUS is safe. It's highly accurate, especially with the new generation needles. We are able to achieve, acquire good tissue, which can be subjected to immunohistochemistry, etc. And interventional EUS is expanding on the day with newer stents, with newer techniques. We are able to perform a lot many procedures with the help of interventional EUS, and it's safe and it is well accepted by patients. And I think interventional EUS is the way forward in many situations for therapeutic endoscopists. So thank you for your attention, and I'd like to end my presentation with this.
Okay. Thank you, Dr. Ankit Dalal. It's a perfect presentation. We have no question, I think, but I can say data is very important or in our daily life. Data is everything now, and EUS endoscopic ultrasound give us really good and detailed data about carcinomas, pancreatic and biliary system. Also, not only data, but also therapeutic side is incredible that you show us incredible videos. Thanks to talented endoscopists like you, patients saved from unnecessary laparotomies or laparoscopies. I want to ask about the educational side. We can divide it basic endoscopic ultrasound and the therapeutic side. What do you, what can you say about the education of endoscopic ultrasound? What number we need, what years, or
Okay.
do you have any recommendation about the education?
So yeah, there's a lot of literature about training in EUS. So anyone who wants to get trained in EUS, now the typical learning curve is that you perform diagnostic EUS in 75 patients and you perform FNAs in about 50 patients to be efficient in linear EUS. Once you have achieved that, you are able to do diagnostic EUS competently on your own. For therapeutic EUS, again, if you have performed about 100 or 150 FNAs or biopsy sampling, needling on your own, then you can start off by performing simpler therapeutic EUS, which is your pancreatic fluid collections. Pancreatic fluid collections are the simplest of all therapeutic EUS. That or performing celiac plexus blocks. Once you have been able to do that, then you can progress on to something like biliary drainages or gastrojejunostomies. Gastrojejunostomies require quite a bit of evaluation, training, and proctoring. So you need to do under guidance to perform gastrojejunostomies or gallbladder drainages, etc. But your training for basic EUS it's well established. You need to do 75 of independent. You need to identify all the targets that you are looking for in 75 patients, perform biopsies in about 50 patients, and then you can be called competent in performing EUS on your own.
Okay. Thank you. Exactly.
Okay.
Dr. Part?
Yeah, very great presentation. It was a gold mine on all the subtopics, and I could see so many topics that you touched on could be a topic of a webinar in itself. And
Yeah, I mean, this EUS is like it's very broad. So
yeah,
for me to
yes,
talk about
I
all of EUS is not possible. Like
yeah, and
we have conferences only on EUS which go on for 2 days.
exactly,
So
exactly. Now, after seeing the whole presentation, I understood what an in-depth scope of topic it is, and even the newer techniques of duodenostomy and all those new procedures I
yeah.
learned about it today itself. I wanted to ask you about uh, how will you choose between ampulectomy versus major surgery, on what criteria again, on which adenomas will you decide?
So ampullary adenomas, they're interesting. So you have a couple of things that you have to look at. There are position papers which have been given out by the American and the European Society of Gastrointestinal Endoscopy. So you're looking at lesions which are typically 2 centimeters or less, non-ulcerated, which do not have intraductal extension of more than 1 centimeter. So if you have lesions which are invading into the duct by more than a centimeter, either the pancreatic or the biliary duct, these cannot be removed in toto at endoscopy. So that's why EUS comes in view gives an advantage, as in we can assess the depth of the lesions within the ducts. So if you have a lesion which is about 2 centimeters not invading into the ducts, you can remove them endoscopically. Of course, malignancies, if on biopsy you have adenocarcinoma, you would subject them to a surgery rather than an endoscopy. But for ampullary adenomas, even with high grade adenomas, you can do ampulectomy if the lesion is not invading deep into the ducts.
And another question was about laparoscopic ultrasound. Do you feel it can complement or help the EUS in any way, or what things are required when that is done? What things to be kept in mind?
So laparoscopic ultrasound, I do not know what are the
No,
I think there's some network issue.
yeah.
EUS pre-op imaging can give you a good guidance in terms of the depth of the lesion or the extent of the lesion. And for bile duct stones, I think pre-op EUS is one of the best modalities you can use. So whether you need an ERCP prior to performing a gallbladder surgery, if you have a clinical doubt and the MRCP is not conclusive, I think an EUS helps a lot. I do not know what the laparoscopic ultrasound. Maybe you can tell me what are the indications of a laparoscopic ultrasound.
It's mainly used along with staging diagnostic laparoscopy, where because of the obviously the need for a laparoscopy. So the main adjunct there is when laparoscopy is being done. But maybe have you ever felt the need that it could be assessed better from the
No,
third
so as
view?
I said, so if you're looking, say, talking about pancreatic CA, EUS, like endoscopic ultrasound, is excellent for local
Yeah,
staging
yeah,
in terms of vessels, in terms of near nodes, local nodes. It's excellent. You can assess the SMV, the portal vein, the SMA, the celiac trunk, the hepatic
everything. Yeah,
artery. Everything can be assessed very comfortably with your endoscopic ultrasound.
yeah, yeah. Okay. I don't see any other questions in the text box. Tawfiq, shall we conclude the meeting?
We can conclude. Thank you. I'm
Do
very
you want to give any closing remarks, Dr. Ankit?
Uh, no, sure. So, I mean, if I mean this meet was, I think, webinar was mainly focused at surgeons. So, I think I just wanted to give
Yeah,
everyone a brief overview of what are the possibilities of EUS, what is happening with EUS, what are we able to do with EUS. I didn't go into the data deliberately because it would have taken a
yeah,
lot
yeah.
of time. And EUS, as I said, on its own has a lot of deeper things that we can delve into. The main thing that I wanted to focus is tissue acquisition, which has changed dramatically, that we are
True.
able to get good tissue now safely without risk of needle seeding. So whenever we need a tissue diagnosis from the pancreas or the biliary tree, EUS guided tissue acquisition remains as a gold standard and safe. Therapeutic EUS is coming up in a big way. There are several procedures which are being done, which were earlier the domain of a laparoscopic surgeon, which are now being done endoscopically. But it still remains a complementary branch. You still need your surgeon to be there. Because these procedures are high risk, they require a level of expertise, and it should not be lightly done because the complications can be catastrophic if you develop if you misdeploy a stent into the peritoneum, or you puncture the jejunum and then do not deploy a stent, you can have a patient going into peritonitis, and then the whole
Sepsis.
picture changes. And these therapeutic procedures require a high level of skill and experience, but they can be done, they can be safely done, and can be an option for patients who are sick, who are not suited for surgical therapies, and can be subjected to a minimally invasive procedure. So, yeah, therapeutic EUS can be used in these situations.
Yeah. So I will proceed with the closing remarks. We will upload this video on the TUGSS YouTube channel, where more than 1,000 surgeons will be able to see this video, and all the participants who have attended will also get the certificate for the same. Over to Dr. Tawfiq for the thank you note.
Oh, thank you, thank you. I want to conclude this. Thank you once again for being part of the this experience. We hope to see you in following webinars.
Yeah,
Thank you,
Thank you.
it was a pleasure to have you.
Thank you so much.
Thank you.
Dr. Ankit.